All right, welcome back to the continuous de-evolution of my sanity. We are going to continue here with diabetes. My goal is if I can get through 300 cards, I mean, it's going to max me out at 189. So let's get through diabetes treatment and we'll see what time of day it is. Oh my goodness gracious. Okay, so again, this is using a strategy I call matrixing. Most of this PowerPoint is going to be all on this one card. Oh, sucks. Hey, bud. I'm going to put some music on, or I'm going to lose my mind. So let's put on some Tycho. This video gets taken down, whatever. Okay. Let's go, baby. All right. Side effects of SGLT2 inhibitors. Can't this cause like pneumonia? GU infections. Great start. Okay. Don't use it in heart failure or evidence of, this is black box warning of TZDs. Renal failure, fluid overload. Oh boy. Meglitinides, Brandon is going to do what insufficiency? Hepatic. Side effects of alpha glucosidase inhibitors. Flatulence. Oh, that's important. Benefits of GLP-1 agonists. Which one decreases nephropathy? This is Victoza. Quick victory there. All right. Lower serum Biguanides. Lower serum what? Glucose? Free fatty acids. Interesting. Benefits, weight loss. Where are we here? Benefits, weight loss, lowers what? SGL2. Blood pressure. Yeah. Rapid acting. It's going to start with a G. This should be, it's not glargine. Oh, glue-lysine. Rapid acting. Tirzepatide Mounjaro is a what agonist? Works on Kisa. Like a GIP? Yeah. SGL2 inhibitors stop 3 to 7 days before surgery and extreme sports. Contraindications don't take with alcohol. It's going to be our alpha glucosidase inhibitors. Stop gluconeogenesis, increase peripheral glucose utilization. Alpha glucosidase inhibitors came in name one. Precose. Side effects of GLP-1s, injection site reaction. A specific one causes diabetic retinopathy. I think Ozempic does. Semaglutide. Yeah, because you're thin and blind. Can't find this one. Oh. What cells produce GLP-1? L cells? Yeah, that's that incretin, right? Meglitinides does what insufficiency? If that does hepatic renal, I think of like ninja stars right to the kidneys. Heart failure patients decreases nephropathy, and what else? SGLT2. ASCVD risk? Good. Blank hepatic insufficiency, Starlix. This should be Prandin. What's your favorite brand of alcohol? And insulin secretatog. This is sulfonylureas. Blank. Glucose independent. which is why it causes hypoglycemia. That's big. Ozempic increases diabetic retinopathy. Pancreatitis, injection site reactions. Most of the GLP-1s are going to be like sub-Qs. Avoid SGL2 if prior DKA. Look for a patient on this med with symptoms of hypoglycemia and take them off this medication. Yeah, you want to take them off these sulfana and the megs. Side effect, hypoglycemia. Benefits for TZD, blank for patients with CVA, just good. Good for patients with, a specific one, pioglitazone. GU infections and UTIs? Oh, okay, I was thinking URIs. All low down there for SGL2. Okay, we'll take that. Look for a patient on this med with symptoms of hypoglycemia and take them off it. So this is, it should be Lantus? No, Glargine, Degludec, minimal peak. Levemir, Dedamir. Start with the highest dose with the TPP4s. This is going to be a really hard exam. This is going to ruin some lives. GU infections, UTIs. What else do we see with SGLT2 inhibitors? Hypotension. I'm actually going to say that. I'm going to take that. Gangrene, DKA risk, stop 37 days before surgery, extreme sports. Oh, 3 days for colonoscopy. Stops blank in the liver. Metformin. It's either gluconeogenesis or glycogenolysis. I'm going to say glycogenolysis. It is gluconeogenesis. Okay, I won't forget that. MOA less effective with GFR less than 45. L cells in the small intestine produce GLP-1 in response to just food. What are our long-acting GLPs? So these are going to be our tides, not liraglutide, not semaglutide. There is semaglutide, the Ozempic is down here, and then dual glutide Trulicity. All right, I mean, I would have gotten that. In insulin, blank, that stimulates the beta cells in the pancreas to secrete more insulin, secretatog. Increasing sensitive adipose and muscle tissue? Yeah. Contraindications, blank, GFR, less than 30, pancreatitis, may need to hold 1 week. What's a big contraindication for GLP-1s? Oh, medullary thyroid cancer. Holy crap. Okay. Bladder cancer. What medication would be a contraindication for SGLT2 inhibitors? Oh, it's not a med, but it's the one that causes bladder cancer. It's Farxiga, dapagliflozin. So knowing that that's an SGLT2. So pioglitazone, good for patients with CVA, TIA. Blank insulin, use these before or with meals. Rapid? Oh, bolus. Incorrect, but you want the general term there. Similar MLA to sulfonylureas, but acts through a different receptor. Insulin independent or glucose independent. Greater than 9% with symptoms is when we bring in insulin for DM2. This is GAL, so this one is going to be aspartate? Aspart, yeah, insulin aspart, Novolog. Benefits weight loss, height. No hypoglycemia. SGLT2 is expressed in the blank and mediates glucose reabsorption. Oh, PCT, okay. So don't put your patient on this, and also insulin, yep. Benefits, no hypoglycemia. Take us with meals. That's your rapids. DM1, you need to give them a basal and a bolus. All right, bottom left, here we go. So what is the name of this? These are DPP4 antagonists. Yep. Which is the renal insufficiency one? Ninja, Starlix. Linagliptin Tradjenta is good for what? I think not CVA, decreased GFR. Okay, lean on her. Benefits, no hypoglycemia. We have weight neutral. Rapid acting GAL. This is going to be insulin Lispro. Benefits, no hypoglycemia, slows gastric emptying. So we get weight loss here with the GLP-1s. Sulfonylureas, just name some. These are your ides. It's like glipizide, glimepiride. Good. Saxagliptin, Onglyza, or blank is a CHF risk. These are just, yeah, allogliptin, Nicena, okay. Side effects, 48 gangrene, blank risk. What's the big one? DKA risk for SGLT2. Gluconeogenesis, whole dose. Yeah, that's better. 48 hours after CT contrast, reduced absorption of B12. Okay. Not blank and excreted exchange, so that not metabolized. Which medicine is a risk? Isn't this like Topamax? Yeah, that's where Topamax is. Okay. Side effects, fractures, Fournier's gangrene sits down there. These are bolus. So we pee out glucose here, no action at pancreas. So our upper corners have no pancreas actions. Benefits, no hypoglycemia, slows gastric emptying. That's going to be for what class? GLP-1 agonist. Eat mostly non-starchy vegetables. You want half of your plate to be non-starch vegetables. Hypoglycemia. The risk for hospitalization for heart failure patients. Liver, I would assume. Oh, adipose. Okay. All have an onset of how many minutes? Rapid eye. 10 to 30? 10 to 20? What's the name of Ninjaro? Something with a T? Terzepatide. I don't know that that's really important to know. Biguanides, metformin. Stops gluconeogenesis in the liver. Bone fractures down here. Side effects of SGLT2s. Cirrhosis. What's a big contraindication here? Oh, IBD. You don't want to do. Okay. That's simply metformin. We're actually moving through these pretty quick. 3 days for colonoscopy. Avoid low carbs and excessive alcohol. Tresiba, which is degludec. So these are our long actings. That's actually the quickest onset, also the longest duration. 43 hours. I wonder if that's supposed to be 48. Maybe it is 43. Extreme sports, blank days for colonoscopy, 3. URI symptoms for what med? It's pancreatitis. They have a P in it. That's a good connection. An insulin secretotug that stimulates the blank in the pancreas to secrete more insulin, just beta cells. Decreases insulin blank. Resistance? Oh, yeah, that's a pretty good benefit. This is basal insulin. not metabolized and excreted unchanged through the kidneys. These are long-acting, used with each meal, oh, before each meal with short-acting. Okay, that makes sense. Benefits, no hypoglycemia. It's not Synjardy, but it's some with an OUN, Mounjaro. Weight gain, fluid retention, heart failure, elevated blank. Side effect. Blood pressure? LFTs. Okay, that's pretty important there. Liraglutide, Victoza decreases what? Nephropathy. L-gliptinicina does what? Is this like CHF risk? Okay. Side effects, blank symptoms. GI, URI. So URI down there, UTI to the right. What's this? Meglitinides. Which one's good for GFR? Linagliptin. DPP4. Just name some. These are gliptins. Linagliptin, allogliptin. Sitagliptin, of course, Januvia. Pioglitazone food for patients with CVA stroke or NASH lives up there. These are short-acting, the ones I'm going to take before each meal. Humulin, Novolin. These are our sulfonylureas, TZDs, the glitazones. Weight loss with Biguanides. That's pretty good. TZDs, just name one. Pioglitazone, Actos. Don't use it in heart failure, evidence of fluid overload. Very good. Side effects, blank and GI upset. Flatulence. GIP agonist works on K cells. Nausea, vomiting, diarrhea, pancreatitis lives here too. Yeah, lactic acidosis, the big thing with Biguanides. GU symptoms, GU infections. Don't use it in heart failure. What's the name of these? Search the globe for glyphs. So these are your glyphlosins, and this is SGLT2. Name some. Empagliflozin, Jardiance, right? Dapagliflozin, Farxiga, and panagliflozin ipicana. Lower serum, not glucose, fatty acids. Basal insulin is where we begin. What's the short-acting GLP-1? These are tides, dulaglutide. Is this, it's not Trulicity, semaglutide, dulaglutide. It is Victoza. Okay. Oh, quick victory makes even more sense because that's the short-acting. That's probably why I did that. And that's the nephropathy one. Long-acting, short-acting, rapid-acting, intermediate-acting. So that's basal. So to the G, this is glucine, glulisine. Hold dose 48 hours after CT contrast. In insulin secretatog, only 30 more, and I've seen them all. These are alpha glucosidase inhibitors. Side effects of TZDs, weight gain, fluid retention, heart failure? A lot of information. I hope this works. Nephropathy. How many days before surgery? 6? 3 to 7. Not incorrect. Bladder cancer with Farxiga. Hold dose 48 hours after CT contrast. What are going to GLP-1 agonists. Contraindications, GFR less than 30. If the GFR is less than 30 for Biguanides, we half the dose. Oh, no. If it's less than 30, we don't give it. Half the dose for GFR, I don't know, 45, 30 to 45. Reduces postprandial glucagon release, decreases blanket brain. It's like your hunger. Yeah, appetite. These are glucose dependent. So no glucose, so no hypoglycemia. Contraindication, GFR less than 30. Benefits, weight loss, lower BP, decreased risk of hospitalization for heart failure. Renal failure, age greater than 65. Decreases appetite at brain. Decreases blank absorption in carbohydrates. Pancreatitis. It's just the other one. Saxagliptin, CHF risk. Risk for lactic acidosis, renal failure. All decreased blank risk as well as CVA, TIA. ASCVD, yep. Any one is blank if we've tried the 8 DM2 meds. Oh, indicated, these long-acting basals. What's the first one? Glargine lantus. CVA, TIA. Side effects, common. GI is a big one there. 7 more. Doesn't Nasina bring LFTs up? Yep, LFTs here, LFTs upper right, good. Names of, this is Prandin or Starlix. Such a cool name, Starlix. Best meds to combine with insulin. We want to combine these insulins with blank and GLP-1. Metformin, GLP-1, SGLT2. Benefits, blank for patients with CVA. Which one's good? Pioglitazone. Bladder cancer, blank, macular edema. Pregnancy, you don't want to give TZDs to pregnant women. That's important. Bladder cancer again. So we have 2 bladder cancer mentions. Best meds to combine with insulin. We want to combine these insulins with metformin and GLP-1, plus or minus SGLT2. All right, we've seen them all. Stops gluconeogenesis. Use these before or with meals. Oh, just in general. Bolus insulin. Contraindication, big one for GLP-1 agonist. What is this one? Oh, medullary something. Medullary thyroid cancer. Why is that men? That's not what that is. Hold on. What am I doing? Oh, medullary thyroid cancer or men. Which is multiple endocrine neoplasia. Oh boy. Gotta fix that. All right. Multiple endocrine neoplasia. Gotcha. Trajenta is good for what? Lean on her. Nephropathy? Not incorrect. Decreased GFR. Reduces absorption of B12. SGLT is expressed in the blank PCT. No hypoglycemia. Weight neutral down there for DPP4. Increase insulin sensitivity by acting on blank and muscle tissue. It's just insulin sensitivity by acting on blank and muscle tissue. Adipose. All have an onset of how many minutes rapid acting? 10 to 20? Nesina, allogliptin, CHF risk. Nesina also raises those LFTs. Cirrhosis, big one here. Contraindication for alpha glucosidase inhibitors. Man, I can't remember this one. Oh, yeah, inflammatory bowel disease. Used before each meal, the short actings, Humu and Novo. What's elevated here? Side effects, TZDs, heart failure, elevated blank. LFTs, good. Side effects, blank symptoms. This is URI symptoms. I could have sworn pneumonia was somewhere here. Brandon is going to be alcohol, so liver insufficiency. Lowers blank blood pressure. Don't take with alcohol. Alpha glucosidase inhibitors. What's the name of this one? Precose, acarbose. Starlix is kidney insufficiency, renal insufficiency, short acting. Short acting. Victoza. Extreme sports down here for SGLT2. Hepatic insufficiency. Brandon. Nephropathy. Good job. Lipids, blank decreases nephropathy, all decrease ASCVD risk. Which one? Oh, Victoza, liraglutide. Oh, yeah. Hypoglycemia, 130. This is a GIP agonist. It's Mounjaro. Stop. How many days before surgery? 3 to 7? Rapid acting. Injection site. In glucose independent. Highest dose. One of these causes diabetic retinopathy, I think. Oh, Ozempic. Yeah. Thin and blind. Bladder cancer. It's right after this. Pregnancy. Increases blank peripheral glucose utilization. Avoid SGLT2 if prior DKA. L cells. Increases nephropathy and ASCVD risk. All right, below 125. This is going to be Levemir, Detamir. And these are the, those are the long actings. Yeah, yep. Look for a patient on this med with symptoms of hypoglycemia and take them off of it. Long-acting GLP-1s. Ozempic is here. The other one. glutide. We should know that. MOA less effective, GFR less than 45. L cells in the SI produce GLP-1 in response to blank, which stimulates glucose-dependent insulin release. Food. Ozempic increases retinopathy. 3 days for blank, not surgery, colonoscopy. Farxiga, GU infections, UTIs. I don't know, hypotension. Think them off it. No hypoglycemia. Glucose independent. This is L. Humalog. Lispro. Don't put insulin with these patients. An insulin that stimulates the beta cells. Secretatog. No hypoglycemia. Muscle tissue, adipose. Not metabolized. What's linagliptin good for? Nephropathy? Not incorrect, but decreased GFR. Hold dose 48 hours after CT contrast. Renal insufficiency is Starlix. Blue lysine, what's missing here? Insulin aspart, Novolin, Novolog, not Novolin, whatever. Take us with meals. Topamax, there's another medicine. Well, no, it's Farxiga, but Topamax. This is side effect. Not a side effect, risk for lactic acidosis. Greater than 9. Yeah, CBA, TIA. Bone fractures. Pancreas. DPP4. Heart failure patients excrete. Basal and bolus. All right, 99, baby. Let's go. Cirrhosis. God, what is this? It's not pregnancy. That's above it. Oh, IBD. Good. Biguanides, metformin. Cornea's gangrene. Name of sulfonylurea. Glyburide, glipizide, glimepiride. No action of pancreas. Slows gastric emptying. DKA risk. Weight loss. 3 days. Long acting. Trulicity, which is dulaglutide, and then Ozempic, semaglutide again. Long acting. Alcohol. Mounjaro. Basil. At the liver. Metformin. Non-starch vegetables. Jeez. Yeah, starch is like potatoes. We don't want potatoes. Half your plate should be it. Name some DPP4s. Alogliptin, Nasina, linagliptin, Victoza. Oh, no, that's liraglutide. Ugh. We'll hit those again. Come on. Good for decreased GFR. Which one? Lean on her. Linagliptin, which is Tradjenta. Your eye symptoms. Contraindications, pancreatitis, TZDs, bolus, hypoglycemia. I don't really care. Tirzepatide. Pregnancy, contraindicated TZDs. Beta cells. Name a TZD. Pioglitazone, Actos. Sulfonylureas. Increases insulin resistance. Less than 75. Let's go. What does Nicina and saxagliptin do? CHF risk? Don't use it in heart failure. Evidence of fluid overload. Victoza decreases what? Nephropathy. Lactic acidosis. GU issues. No hypoglycemia. Tresiba de Gludec. Side effects, GU infections, UTIs. Hypertension. Not metabolized and excreted unchanged through the kidneys. Meglitinides. Blue lysine. Short acting. K cells. Intermediate acting. Linagliptin Tradjenta is good for what? Reduce GFRs. Benefits, weight loss. And insulin, secretatog. Insulin. Lower serum fatty acids. NASH. Flatulence. Fluid overload. Pancreatitis. After CT contrast. Half dose GFR 30 to 45. Benefits, weight loss, lowers BP, decreased risk of hospitalization for heart failure patients. Alpha glucosidase inhibitors, name one. Precos. It's the only one. Basal insulin is where we start. Name some SGLT2 inhibitors with gliflozins. Empagliflozin, Jardiance, dapagliflozin, Farxiga, panagliflozin, Invokana. Let's go. All right, less than 50, 44. That was my dad's number. Age greater than 65. DPP4. All right, easy here. This is T, so this is Liptin. This is gliptins. Allogliptin, which is Nicina. Linagliptin, which is Tradjenta. That's all I remember at the moment. Januvia. I don't know why I keep forgetting Januvia. Linagliptin, Tradjenta, L-gliptin, Nicina. Good. GFR 30 to 45. We're going to half our dose. This is such a brutal week. I don't know, man. Bottom is SGLT2 inhibitors. Nausea, vomiting, diarrhea with Biguanides. Yep. So I have that long-acting one. Blanker, Alagiptin, is CHF risk. The one with an O, Onglyza, Saxa. Nicina also increases LFTs. Yeah. Decreases appetite at brain. 38, baby. Carbohydrate. Long-acting. Detamir, Levemir. This is Glargine-Lantus. Fluid retention. Heart failure. So heart failure is here. That's a side effect of heart failure, though. This is good for heart failure. Uh-oh. Increased LFTs, increased LFTs. Yeah, I'll remember this is good for heart failure. SGLT2s are awesome. Heart failure is the big black box warning with TZD. I think I'll remember that. Glucose dependent. Name some Meglitinides. Oh, Prandin or Starlix. I don't really care about Repaglinide or Nateglinide. It's jam. We want to combine these insulins with metformin and SGLT2s or GLP-1s. Speaking of GLP-1s, good Lord, Panky. That's one big tide or gulp. Gulp because you see a big tide coming in. GLP that connects. You get it? 48 hours after CAT scan. Contrast. Decreases appetite at the brain. Bladder cancer with Farxiga. Anyone is first line. Conjugate GFR less than 30. Yeah, I would think so. All decrease ASCVD risk. Metformin. Renal failure. Glucosidase is good there. Stops gluconeogenesis. Third time I'm seeing that one. All of an onset of 10 to 20 minutes. Nicena CHF risk. Contraindications with type of cancer. Isn't it bladder again? So that's contraindications of bladder cancer. Same thing here for Farxiga. Oh, so Farxiga doesn't cause bladder cancer. You don't want to use it with bladder cancer. Make sure I'm not getting my wires crossed. Use these before with meals. Bolus insulin. Contraindication, big one with GLP-1 agonists. I don't know. Medullary thyroid cancer or men. Best meds to combine with insulin, metformin, GLP-1, or SGLT2. Use before each meal. All right, we're down to 16. SGLT2 is expressed in the proximal tubule. Side effects, URI symptoms, DPP4s, cirrhosis, big one here, big contraindication with alpha glucosidase. Oh, inflammatory bowel, elevated LFTs, side effects. Stop 6 days before surgery. 3 to 7. That was coming into my brain as I said that. Weight neutral with DPP4, absorption of B12. Increases insulin sensitivity by acting on blank and muscle tissue. Adipose. Decreases nephropathy. Medullary thyroid cancer and MEN. Short-acting Victoza, liraglutide. Long-actings here are dulaglutide, which is Trulicity, and then Ozempic. Contraindications, bladder cancer, blank macular edema, pregnancy is a big one there. 3 more. DPP4, name some. Sitagliptin, Januvia, linagliptin, Tradjenta, alogliptin, Nicena. Good. And saxagliptin. Big side effect here, SGLT2 inhibitors. Hypertension? What's linagliptin, Tradjenta good for? We can lean on her for reduced GFRs. That wasn't bad at all. That wasn't bad at all. There we go. We broke 1,000. It's limiting me at 41 because it only wants me to do 500 cards a day. But I definitely want to finish. We have some reviews here. Inhibitors of glucagon. What with just increased sugar? Paracrine insulin. Increased sugar, paracrine insulin. Somatostatin. You knew that. Oops. LDL is what? Less than 100. Triggers hepatic glucose and ketone output. Inhibited by somatostatin, paracrine insulin, and glucose. All right, we're gonna pause here and we will come back. I'll probably get, oops. Whoa. I'm probably gonna eat first and then come back. All right, right back at it. Let's hit these reviews real quick. Glucagon is inhibited by paracrine insulin, glucose, and somatostatin. Whoops. Good. GLP-1 contraindications, medullary thyroid cancer and MEN syndrome. Cirrhosis, big inflammatory bowel disease contraindication. Good. All right. 141 to finish this day. Sanity. Okay. So we're talking about diabetic medical emergencies. We're talking about complications here. Tachypnea. We're going to go with Kussmaul breathing. This is for DKA. Presentation here. This has GI symptoms, nausea, vomiting. Yeah. All right. Necrobiosis, lipoidica, diabetic. Are you out of your mind? Treatment. Is this just topical steroids? Yep. Necrobiosis. It's NLD. I mean, come on. Oh, within what year of screening for retinopathy for type 1? 5? Potassium. So when we are fixing DK and HHS, we want to avoid causing hypokalemia because we're going to be giving them insulin, which is going to push potassium out of the cells, right? All right, we're talking retinopathy, microvascularization. So, oh no, okay, microaneurysms, pericyte and fat deposition. Diabetic ulcers, 2% result in amputation. Screening for diabetes to avoid complications, you'll probably know this, what stands out. Aspirin therapy, daily actually for those with CV risk factors, foot exam at every visit, and A1C 3 to 5, no, 2 to 4. I think there's a 4 in there. Yeah, that's crazy. Nephropathy, diabetic nephropathy will progress to blank milligrams urinary protein excreted per day. 100, 300. 3 important vaccines to avoid diabetic complications. Hep B for less than 59. Flu, probably pneumococcal. Nephropathy again. Yeah, we have to confirm that positive twice because a lot of things can cause transient microalbuminuria. Treatment. So when we're doing HHS, the big thing here, yeah, if their sodium is normal or hyper, we want to give them 0.45 hypotonic. We don't want to overload their saline. 50% of patients with blank on dialysis have DM, end-stage renal disease. This is called, what is this called? It's not just diabetic neuropathy. Glove neuropathy? Distal. We'll take that. Advanced. So these are our AGEs. 4 big effects here: an acceleration of atherosclerosis, a promotion of kidney dysfunction, glomerular, we'll take that. Treatment, fluid loss, a lot, like 8 to 10, which actually lines up nicely because the glucose is 800 to 10,000, and glucose is 350 to 500, and this is 3 to 6. Shiny reddish brown patches with yellow centers, that's going to be NLD. Treatment, fluid loss to normal saline with DKA. We'll see high serum osmolality with HHS, that's important. Critical hypoglycemia levels, less than 50, okay. Impaired blank function. It's not wound healing, vascular, neutrophil. Transient asymmetric neuropathy and abrupt painful onset of motor loss and isolated cranial peripheral nerve, yet a limited duration. Yeah, so it sounds bad, but it's transient. Glucose 800 to 1,000, 350 to 500 there. How to treat the dawn phenomenon. You're going to up your PM insulin. Good. Fruity breath. Shiny reddish brown patches, that NLD. Less than 30 is going to be loss of consciousness and seizure. GU. So yeah, within the bucket of neuropathy, under autonomic neuropathy, we're going to be getting erectile dysfunction. We do get ketones in our urine with DKA. Common infections: candidal, periodontal, malignant. Yeah, malignant ear infection, okay. Metabolic anion gap acidosis. Beta blockers blunt the SNS response with hypoglycemia. Diabetic foot exam, causes, meds, SGLT2 inhibitors can cause DKA. Yeah, that was in that box too, so this is a good connection here. Is a first sign of disease of nephropathy. Microalbuminuria. Plasma osmolality, again, that high osmolality in HHS. Most common cause of blindness in the US, increased risk of cataracts and glaucoma. Blank kit, all patients on insulin should have one, sub-Q-IM glucagon kit. A relative insulin deficiency and inadequate PO intake, that's big for HHS. So how do you know if you're dawn or Somogi? Set your alarm for 3 a.m. and check your sugar. If it's elevated, it's dawn, low, Somogi, some Logi. Weight loss, big one for HHS. So we saw weight loss. Ooh, where else did we see weight loss? Oh, diabetes 1, DM1. So don't get your left and right confused there. Make DM1 make sense. You can talk through that. This one, I don't really understand. I guess because we have so much sugar, we're peeing out our weight. I don't know. No ketosis because there's some insulin. So what is our bicarb here? Just normal. A blank of peripheral nerves and loss of nerve fibers. Is this demyelination? Yes, it is. Hyperglycemia, metabolic anion gap acidosis with DKA. Treatment for distal neuropathy, pregabalin, which means that gabapentin neurontin should be in there. Transient autonomic, asymmetric. Okay. Advanced glycosylation end products, a decrease in blank synthesis, nitric oxide, believe it or not, and induction of endothelial dysfunction. Low Somogi. Thickened basement membranes. 19 grams. You want to give them what, 15? You want to give them 15 to 20 if they get some symptoms. What's in the middle here? Nephropathy, all microvascular causes. HHS, hyperglycemic, hyperosmotic state. Hyperglycemia, metabolic ketosis, beta hydroxy. You get this down and out with neuropathy. Is it also 5 years after DX? Yes. And then yearly. But with retinopathy, most common cranial nerve 3 down and out. And something kind of interesting, beta blockers blunt the SNS response in response to hypoglycemia. Insulinoma. Beta blocker. Oh, an ACE or an ARB. Most common in blank DM, type 1. Charcot's joint. This is that rocker bottom deformity. I don't care. Necrobiosis. I'll recognize that. Hallmark 4-foot collapse leading to a rocker bottom deformity. When blood glucose hits 250 to 300, we now add glucose via what? I think it's just D5 with 45. Yeah. Glucose control, refer to blank. Hey, bud. Ophthalmology, they're going to give Avastin, typically seen in type 2 diabetes. All right, we're down below 71 for new cars. HHS 800 to 1,000. For every 100 over 100 of glucose, add back in 2 of sodium. I don't have energy to explain that right now to myself. Most common cause of blank in the US, retinopathy, blindness, actually. That's crazy. An abrupt, painful onset of motor loss, this transient asymmetric neuropathy. That's pretty crazy. Just motor loss in a peripheral nerve. These are blank proteins, small, so they can't be identified with urine dip. So I guess microscopy, we're looking for there. Want to make sure they're hemodynamically stable before we start pushing electrolytes. GI symptoms on the left, we're going to have neuro on the right. So peripheral neuropathy, ataxia. Not exactly. Altered mental status, focal neurologic findings, seizures. This is the Somogyi effect, that it's about rebound against that medication. It's actually Dawn's dose caused this rebound. Oh, here's our pneumonia. So pneumonia can cause DKA. Something called hypoglycemic unawareness. Consciousness. Framingham. Autonomic neuropathy. Once patient is 10, then we do it yearly. Abrupt painful onset of motor loss. Ophthalmologist for Avastin. Neovascularization, so this is proliferative, are the neovascularizations emanating from the optic disc. Since it's acidosis, bicarb will be low. Evolves slowly, usually over just it's days to weeks. Yeah. This is going to be diabetic retinopathy. Yeah. Gabapentin neurontin, which means we can also use pregabalin lyrica. blank, irritability, blurred vision, fatigue, headache. Confusion. End-stage renal disease is defined here as excreting blank protein a day. Five grams, 4 grams. Often seen with blank. LADA, DKA, LADA. Yes, yes. LADA can present with both of these. Atypical antipsychotics, more meds here. Isn't this one that comes up a lot? Dobutamine. Double check that their potassium is not less than 3.3. Good. Or else we need to fix that first. Treating hypoglycemia. You want to instruct your patient on symptoms to look out for and instruct them to ingest 15 to 20 grams of fast-acting carbs like Coke or orange juice. All right, we're doing good. 44. It's my dad's number again. All right, how do we know the source? Check a C protein. Not C protein, C peptide. Ooh. C protein is a cardiac marker, yeah? Blurred vision, 800 to 1,000. Sub-Q insulin after you're done everything down there. Autonomic neuropathy. Just diabetic neuropathy. Stop drip once the what resolves, the anion gap. That's big there. For every blank over 100 of glucose, every 100. While in insulin drip, blank hour Accucheck's Q1, so they're in the ICU because MedSurg can't do that. 350 to 500 there. Marked ketogenesis. Malignant otitis externa, blank sinusitis. Fungal? Yeah, that's crazy. You get leukocytosis, so high amounts of white blood cells, proportional to the degree of ketosis. Sure. So the fluid of choice. All right, so let's walk through this. So we started our fluid. We're double checking their potassium's not less than 3.3. We're gonna put some potassium in. Why? Why are we doing this? Well, the problem here is that they have too much sugar, right? What's the solution to that? Insulin. What's insulin going to do? It's going to push potassium out of the blood, and it's going to make them hypokalemic. So we're going to be replacing potassium as we boot it into the blood. That's why we're going to do 45 normal saline. Now, why can't we do normal saline? If we're already pumping them full of fluid because they're in DKA, which would be normal saline, well, if we add potassium, we're adding too much tonicity. Remember, there's some salt in normal saline. That's what? Oh, 0.9, not 3, 0.9. So if we add potassium, that's another solute. That's too much tonicity, right? That's going to be hypertonic, and it's going to make cells lyse, or it's going to have fluid rush out of there. So what we do is we knock it down. If they're not already on half normal saline because they're in the HHS track and they were eunatremic or hypernatremic, then we stick them on half normal saline and we put in, I think it's 20 to 40 MEQs of potassium. Yes. Good. Can also consider a SGLT2. Yeah, because those are good with nephropathy. Another good connection there. We'll see blank osmolality increased. IV access, 1 amp of, this is hyperglycemic emergency. This is in adults. 1 amp of D50. No IV, you give them IM glucagon. Trauma, major illness, MI, CVA. Pancreatitis, causes for DKA, okay. And those DPP4s, GLPs can cause pancreatitis as well. DKA. Gastroparesis. Yep, then you can push your insulin. And then we start replacing glucose because the glucose is it's like, what, 300 something? Microaneurysms lead to those cotton wool spots. This is non-proliferative, so that's going to be first. 45. Yeah, this is just the more sugar that gets stuck and glycosylated, it causes all this. Proliferative. It's not microaneurysms, it's neovascularizations. Autonomic neuropathy, resting tachycardia. No ketosis, because we have some insulin, we don't need to make ketone bodies. May start with normal saline unless patient is hypernatremic or eunatremic. Ischemia. Yearly. Eat something before you go to bed. And decrease your PM insulin. Fatigue. Blurred. No, it's blurred vision. Fatigue vision. In a hyperglycemic emergency for kids, beware that D50 can cause venous sclerosis. Most common complication of diabetes. Yeah. We'll see high serum osmolality. This is important because of the saline we're about to give them, which may need to be hypotonic. Again, that's why that 45 NS is the start there. Need to confirm a positive result twice here for our microalbuminurias. Diabetic ulcers occur in 50% of diabetics. Yearly again here for screening. Non-proliferative microaneurysms lead to parasite and fat deposition, cotton wool spots, stopping insulin, infections, pneumonia, and upper URIs. Oh, UTI. Oh. Okay. HHS, the patient is, awake and alert. That's when you can stop the insulin drip. Diabetic nephropathy will progress to blank mg urinary protein excreted per day. Oh, not 300 milligrams. Cymbalta, duloxetine. Pretty interesting treatment. Patient indication, don't go barefoot. Wanna break down. In a hyperglycemic emergency, D5 for children, D1, is that a thing? Okay, no, D10, D5. Common infections, candidal, periodontal, malignant otitis externa. So this is ulcers and general infections. Impaired, can't get to their target, impaired. What is this? Neutrophil. Transient. I don't know this word, asymmetric. Once microalbuminuria presents, all type 2 diabetics should be at an ACE or an ARB. This is where we get neuro, it's focal deficits, seizures. Yeah, we'll take that. End-stage renal disease defined here as excreting greater than 4 grams of protein per day. Treat with dialysis transplant. I don't think we're going to ask that. Blank irritability, blurred vision, fatigue, headache, difficulty speaking. I don't know, weakness, confusion. Atypical antipsychotics, dobutamine is over there, often seen with. Oh, wait, I know this. LADA. Good job. Tachypnea, Kussmaul breathing. This is going to be GI stuff over here. Nausea, vomiting, abdominal pain. Hopefully that's like a softball question. Please. This is going to be lotion. It's topical steroids here. Or injectable. Within 5 years of diagnosis, And then once they're 10, do it yearly. Okay. Potassium, we want to be careful about causing hypokalemia. 2% result in amputation. All right, we've seen every card. 125. Let's go, baby. May start with normal saline unless patient is hypernatremic or eunatremic, then get 45. This one's actually not too bad. I thought this was going to be much worse. Aspirin therapy daily, foot exam at every visit, hemoglobin A1C 2 to 4 times a year. 50% of patients with blank on ESRD. Necrobiosis, something with an L. Lipodiabeticorum. Sure. Need to confirm positive result, transient atherosclerosis, kidney dysfunction, glomerular. They need the flu, pneumonia, Hep B if they're less than 59. Trauma, major illness, MI, CVA. Pancreatitis, less than 50, less than 30 is going to be that critical loss of consciousness and seizure level. Ketones, fruity breath, beta blockers, up your PM insulin, 350, osmolality, blurred vision. Is it not peripheral? Distal. Increase in HHS, shiny red-brown patches, yellow centers, transient, anion gap, normal bicarb, D10 for children, D5 for infants, 8 to 10, gabapentin, Neurontin. It's not unilateral, but something asymmetric, whatever. 800 to 1,000, less than 50. Microalbuminuria. Normal saline. Nephropathy. PO intake. Metabolic anion gap. Acidosis. Pneumonia and not up top, UTIs. Foot exam. Neutrophil. Marked out as hard. Glucagon kit. Weight loss. It's elevated, it's dawn. Erectile dysfunction as a part of autonomic neuropathy. Down and out. Nitric oxide and induction of epithelial dysfunction. That's big, a decrease in nitrous oxide synthesis. Glaucoma. SGLT2 inhibitor can cause diabetes or can cause DKA. Confusion. If it's low at 3 a.m., it's Samogi. Ophthalmology, 5 years. Type 1 for DKA. For every 100 over 100, you need to add back in 2 of sodium. Why that happens is because when somebody is hyperglycemic, the high tonicity of the blood draws in extra water, okay? Which creates a relative hyponatremia. So what happens is when you take somebody's sodium and their sodium's like 130 and you think they're hyponatremic, but their sugar is like 700, for every 100, so that would be 6 times 2, you would add 12, and that would be 142, which I think is normal. So that's the idea there. It's not necessarily the sugar that is throwing off the sodium. It's the fluid that came with the sugar because of the high tonicity. All right, distal neuropathy, a blank of peripheral nerves, demyelination. Insulinoma with C-peptide. It will create C-peptide. If you take too much of your insulin med, it will not, because C-peptide comes from endogenous. 6 ounce of OJ and Coke, 19 grams, so that's perfect. 6 ounce, is that? I think a can is like 12, isn't it? They make those small ones, which I think are 8. Trauma, major illness, MICVA. Oh, it is right there. Oh, it's gonna kill me. Turn the O in it. No, pancreatitis. Microalbuminurias, first sign disease. These are small proteins. Something with an N. Necrobiosis. Congratulations. Low bicarb and ketosis. HHS. 4-foot collapse leading to a rock or bottom deformity. Thickened basement membranes. Advanced glycosylation end products. More ketogenesis via creation of hydroxybutyric acid. Just throw a beta in front of there. We'll take that. Charcot joint. His shtick was that we actually get hypoglycemia because the body rebounds against medication-induced hypoglycemia. Yeah, it's like you give insulin and the body, like out of spite, spikes your sugar like at 4 a.m. So you wake up at 7 and it's huge. So this is Samoghi's effect. All right, when the blood glucose hits 250 to 300, we now add glucose in via, it's not D50, it's just a little sprinkle of D5 with a 45 normal saline. Remember the tonicity, we should keep it at 45. An abrupt, painful onset of motor loss. Hemodynamically stable. All right, we're below 70. 5, 3. Retinopathy. Beta blockers blunt that effect. Typically seen in type 2 DM. Just remember the weight loss is on the other side. HHS 800 to 1,000. MICVA pancreatitis. Non-proliferative, this is going to be proliferative with the neovascularization. Loss of consciousness. Autonomic neuropathy, that's the one with erectile dysfunction. I think that's important. Double check that their K is not less than 3.3. Avastin, whatever. Eventual desensitivity here, something called hypoglycemic unawareness. Low bicarb, DKA. Lyrica, pregabalin. Autonomic neuropathy. 15 to 20 for a hypoglycemic emergency at home. It's like patient education, right? An abrupt blank onset of motor loss. Painful. Days to weeks. Most common cause of blindness. Fungal sinusitis. Sub-Q. Pneumonia. Then 5 years of diagnosis once the patient is 10, then we can do it yearly. Okay. What is the 5-year thing? Within, you want to hit it 5 years. That's 5 years after within 5 years of diagnosis. I think it's all the same thing. Type 2, though, is at the time of diagnosis. You want to screen within 5. That's important. I'm kind of missing that. Within 5 for type 1, at time of diagnosis for type 2. Check a C-peptide. Blurred vision. Framingham study. Anion gap. 800. SGLT2, which can cause DKA. 500. Less than 50. Let's go. While on an insulin drip. Q1 hour AccuChecks. Non-proliferative is first. Gastroparesis. Microaneurysms. Ketogenesis. Neutrophil. Leukocytosis. Just diabetic neuropathy. For every 100 over 100, we add back in 2. Unless patient is hypernatremic or eunatremic. Then we give 0.45. We'll see high serum osmolality. That's why. No ketosis. 45 when we add in the potassium. So not on it already. Confirm it twice. $20 to $40K. Some baltoduloxetine. Ischemia. Sclerosis. Vasculars, nope. Aneurysms. Awaken alert. Ulcers. Neovascularization. IV access 1 amp of D50 IM glucagon. Fix their potassium, then push your insulin. DKA. For type 2, for both of these, at the time of diagnosis and then yearly. For type 1, it's within 5 years. So type 2, a little bit more serious, I guess. Yeah, we already kind of talked about this. $17 left. 300. Decrease your PM insulin and have a snack. That's crazy because the saline we're about to give them, which may need to be hypotonic. LADA. Altered mental status, focal neurologic deficits, seizures. Don't go barefoot. Test the water temperature with your elbow, trim your toenails, and don't have your shoes too tight. And change your socks. ESRD. Yearly. Dobutamine. Otitis externa. 4. Asymmetric. Pancreatitis. Blurred vision. UTI. Infusion. D10 for children, D5 for infants, if you have IV access. If not, we do IM or SQ glucagon for kids. Neutrophil. There it is. 1,387. I just hit a personal record. My last personal record was for the last CMPP exam, which was just under 1,300. This semester is absolutely insane. Test is in 3 days, and I haven't even touched, well, I have resources for thyroid and stuff, but all right, I hope this strategy works. I mean, it's worked for a semester and a half, so we just got to keep going. We'll hit all these cards again tomorrow, and that should go faster. It should start building up retention as we roll into Wednesday. We should have a really solid understanding of these first 4 and rely more on short-term memory for these last 3. And we'll see what happens. All right, I'll see you in the next one.